Hello everyone and welcome to our module on herpes viruses. This is our overview slide of the DNA viruses, and I discussed this in more detail in the module on DNA viruses, but I just want to point out to you that the herpes family of viruses is right here. They're all enveloped and there are a number of them, and we're going to talk about all of these in this module today. The herpes viruses share many common features, and that's why it's good to consider them together. They are all enveloped viruses and they all have a double-stranded linear DNA genome. They all have an icosahedral core, and they are very big viruses. Among the DNA viruses, only the pox virus family is larger than the herpes viruses. They replicate in the nucleus, and importantly, they take their envelope from the nucleus of the cell, from the nuclear cell membrane, not from the cell membrane, which is where most viruses get their envelope from. Another special feature that many of the herpes viruses share is that they often cause a latent infection. So people who get infected with herpes viruses will often have an acute illness followed by an asymptomatic period, but during that asymptomatic period, the virus is hiding in their body, usually in a nerve ending, and then it can reactivate later and cause disease. 4 of the herpes viruses can lead to giant cell formation. These are herpes simplex virus 1 and 2, and varicella virus and cytomegalovirus. And this is a picture of multinucleated giant cells on the screen here. And one of the ways you can diagnose a herpes simplex infection is to take a scraping from a vesicle. We'll talk about this later. And look at it under the microscope. This is called a Zank smear, and if you see these multinucleated giant cells, then that's one way to diagnose herpes infection. So there are many clinically important infections caused by herpes viruses. Oral and genital herpes are caused by the herpes simplex virus. Many of you have probably heard of the disease mono or mononucleosis. This is caused by a herpes virus called the Epstein-Barr virus. Chickenpox or shingles is caused by a herpes virus called varicella zoster virus. There's an infection called roseola. Kaposi sarcoma, which are skin lesions, can be caused by herpes viruses. And finally, there are many infections caused by cytomegalovirus, and cytomegalovirus is a herpes virus. Let's start by talking about herpes simplex virus 1, herpes simplex virus 2, and varicella zoster virus. These are all herpes viruses, and they cause very similar infections just in different portions of the body. So HSV1 causes oral herpes, and it causes a few other infections, which we'll talk about in a minute. HSV2 generally causes genital herpes. It can also cause neonatal herpes and meningitis. We'll talk about that in a minute. And then finally, varicella zoster virus is what causes chickenpox or shingles. So as I said, these 3 viruses share many similarities. They all have a primary infection phase, then they all lay dormant in the nerve ganglia of some part of the body. They can all reactivate later, and they're all treated the same way, generally with the ovir drugs like acyclovir, valacyclovir, and famciclovir. So let's start by talking about herpes simplex virus 1. This virus favors the oral mucosa. It's transmitted from person to person in saliva, and many people who are exposed never develop symptoms. They remain asymptomatic, and we know this because many people have antibodies to HSV1, but they've never had symptoms of an infection. The common initial infection is called gingivostomatitis. This is a severe sore throat with painful vesicles on the throat and in the pharynx. I'll show you a picture of that in a minute. Now, once people are infected, even when the infection resolves, the virus usually lives in a latent state. It hides in nerve cell bodies in ganglion neurons, and it likes to hide especially in the trigeminal nerve ganglion. And you should remember this for step 1 because they like to ask you which nerve the virus is hiding in. Once the virus goes into the latent state, it can then sometimes reactivate later, and when it reactivates, the syndrome people get is called herpes labialis. This is a picture on the left side of the screen of a person with gingivostomatitis. You can see that the throat is red and that there are little vesicles on it. This person will be complaining of a sore throat. On the right side of the screen is someone with herpes labialis. It classically reactivates and causes vesicles at the edge of the lips. That's called the vermilion border. The lesions of herpes labialis are often called cold sores, and don't confuse these with canker sores, which are also called aphthous ulcers. So cold sores from herpes occur at the vermilion border, like in this picture down here at the edge of the lips. Canker sores occur inside the lips or on the buccal mucosa. They're usually not preceded by vesicles, and these are not infectious. Canker sores are an immune phenomenon. We don't really understand what triggers them, but people will sometimes get these sores on the inside of their mouth, and then they will go away after a few days or a few weeks. There are some other infections that herpes simplex virus 1 can cause. One is called a herpetic whitlow. This is when the virus gets inoculated into a break in the finger. It classically happens to healthcare professionals who are taking care of people who have herpetic lesions. It will result in a painful lesion at the fingertip. This is a picture of a herpetic whitlow lesion here on the screen. HSV1 can also cause keratoconjunctivitis, so this is infection of either the cornea or the conjunctiva. Patients will complain of pain and redness and discharge from the eye. And then finally, HSV1 can cause encephalitis, and it classically likes to infect the temporal lobes of the brain. Moving on, let's talk about herpes simplex virus 2. So in contrast to HSV1, which favored the oral mucosa, HSV2 favors the genital mucosa. This is a sexually transmitted infection, and often the initial infection is asymptomatic, so people's first experience of symptoms is often a reactivation syndrome. The classic symptoms of initial infection and reactivation are painful ulcers in the genital area. The initial infections are generally more severe. Those patients often have fever and lymphadenopathy. The reactivation symptoms are often less severe and consist mostly of ulcers. This virus likes to enter a latent phase and hide in the lumbosacral ganglia. So this is another high-yield fact to remember. This is where it hides between eruptions. The recurrent eruptions, as I said before, look like vesicles and ulcers in the genital area. Sometimes they can also be in the anus. And some people have frequent recurrences, so they will take suppressive therapy, for example, with acyclovir. So even though they're asymptomatic, they'll take acyclovir every day to decrease the likelihood that they'll have a flare-up. And HSV2 can also cause meningitis. So remember that HSV1 sometimes causes encephalitis of the temporal lobes. HSV2 sometimes causes meningitis. Both can cause central nervous system infections, but they are different infections. There is a congenital herpes infection that happens to newborn babies when they pass through the birth canal of infected mothers. If mothers are known to have active HSV lesions, they'll often deliver them by cesarean section to avoid exposure. A serious infection in the baby is more common when the mother has primary infection. Always remember that primary infection is worse. It's more symptomatic and it's more dangerous to the baby. When a mother has a primary infection, there are more viruses replicating because the mother hasn't mounted an immune response yet, and she doesn't have a lot of antibodies around yet, so there are fewer maternal antibodies to protect the baby. Babies can get vesicular lesions that look like typical herpes lesions, but instead of just occurring in the genitals, they can occur in the skin, in the eyes, and in the mouth. Sometimes this can progress to severe disease of the central nervous system, including encephalitis, and newborn babies won't have typical adult symptoms of encephalitis like confusion. They will have things like seizures and poor feeding. An important thing to remember about this congenital infection is that there are no congenital defects. Some of the worst features of congenital syphilis and rubella is that they leave children with permanent defects in their heart or in their limbs. That doesn't happen with herpes. The problem is really just the infection and that the baby can get very sick from exposure to the virus. Now let's talk about varicella zoster virus. So varicella zoster is a herpes virus that is spread through the air from infected persons. And a primary infection with varicella zoster is called chickenpox. And nowadays most kids don't get chickenpox because there's a vaccine. But when I was a first grade student in elementary school, I got it and it spread through my school and lots of kids got it at the same time. It's highly contagious. It causes fever and a sore throat and then a diffuse vesicular rash. So there will be vesicles on the face and the trunk and the limbs, and it's very itchy. This is one of the worst parts of having chickenpox is the itch. Classically, there's a progression of the lesions. So they start as macules and then they become papules and then they mature into vesicles. And one of the classic ways to describe it, especially in a board question stem, is for the lesions to be at different stages in different parts of the body. So there'll be macules in some places and papules in others and vesicles in others. Eventually the lesions crust and then fall off. Rarely it can have serious complications. This is usually when adults get chickenpox. So if an adult's never been exposed or vaccinated and they get a primary infection as an adult, they're more likely to contract encephalitis from varicella zoster or pneumonia from the virus. Just like many of the herpes viruses, varicella zoster can enter a latent phase and lie dormant for a long period of time, up to many years. When you get a reactivation illness of varicella zoster, it's called a herpes zoster infection. The virus likes to lay dormant in the dorsal root ganglia of the spinal cord, and it's high yield to remember that. This means that when it reactivates, it will follow a dermatome that is supplied by the spinal cord. So this is a patient in this picture here who's got varicella zoster on his chest. And you can see that the lesions are following a dermatomal pattern. Importantly, they don't cross the midline, and that's because on the other side of the midline, that area is supplied by a different dermatome and a different spinal root that is not infected by the virus. Varicella zoster has an interesting clinical presentation. Prior to development of the rash, most people enter what's called the pre-eruptive phase, which can last up to 10 days. During this phase, there is no rash, but patients have sensory phenomena along the dermatomes that are infected. Usually it's pain, but less commonly it's other sensory symptoms like itching or paresthesias. Sometimes they additionally have other rare symptoms like malaise and myalgia and headache and photophobia. But importantly, there is no rash. This is often mistaken for a muscle injury or some other disorder, and then the rash develops and it becomes obvious that it's a zoster infection. When the rash develops, that's called the eruptive phase, and patients develop a characteristic rash with pain, usually along a thoracic dermatome like I showed you in the last picture. and sometimes there can also be lymphadenopathy present. Usually the eruptive phase resolves over a few weeks or a month or so, but sometimes patients go on to develop what's called post-herpetic neuralgia. This occurs following resolution of the zoster infection and rash. Patients are left with constant or intermittent stabbing pain. It can last for months or even years, and it can be a severe and debilitating chronic pain disorder. Now, lots of us are exposed to this virus, but very few people will develop a herpes zoster reactivation infection. So what are some of the risk factors? Well, age is the most important risk factor. A herpes zoster infection is largely a disease of the elderly. It's very uncommon before age 50, and it's much more common with each decade of life beyond 50 years of age. It's also more common if you're immunocompromised for any reason. The virus can reactivate. This happens in transplant patients and patients on immunosuppressive drugs. And one group you should know about that often has severe and sometimes life-threatening herpes zoster infections are patients with inflammatory bowel disease. Now, they are often on immunosuppressive drugs, so that's one risk factor, but in addition, for reasons we don't understand, just the IBD itself is a risk factor for a severe infection. There are some rare complications you should know about. You can get a zoster infection that spreads to the eye. This can lead to blindness. This happens when the virus reactivates along the trigeminal nerve root. You can also get encephalitis if you develop a severe infection. The treatment is usually supportive in people who have just a rash and mild symptoms. Sometimes steroids are given and acyclovir drugs to prevent post-herpetic neuralgia and if it's a severe case of zoster. There are several methods of diagnosis for herpes simplex and varicella zoster infections. Often these are just diagnosed clinically. If you see a characteristic rash, the rash will just be treated without any diagnostic testing. If you need to do a diagnostic test, some of the options include PCR to identify the DNA of the virus. This is especially helpful when you think someone has encephalitis. You can test their cerebrospinal fluid. There's a viral culture that can be done. It takes several days for the virus to grow in culture. And there is serology to identify antibodies. This is most useful in primary infection. People who have a reactivation will have positive serology from the primary infection they may have had in the past. You can do a Zank smear, which I talked about previously. This is where you take a scraping from one of the lesions of herpes simplex or varicella zoster, and then you look at it under the microscope, usually after staining with the Giemsa or Wright stain, and it's a positive Zank smear if you see multinucleated giant cells. And then finally, if you biopsy infected tissue, you can see characteristic intranuclear inclusions. These are called Cowdrey A inclusions, and they're small, dark intranuclear inclusions on the tissue sample. Our next herpes virus is the Epstein-Barr virus, and this is the causative agent of infectious mononucleosis, which most people just call mono. This virus is spread by direct contact and saliva, and for that reason many people call it the kissing disease. This virus likes to infect and transform B cells. The way that Epstein-Barr enters B cells is high yield to know for your board, so let's talk about that right now. On the envelope of Epstein-Barr virus is a glycoprotein called GP350/220, and this glycoprotein can bind to the B cell receptor CD21, and that's how Epstein-Barr virus binds to B cells and then gains entry. CD21's normal function is as a receptor for the C3d fragment of complement. You may not be familiar with C3d because it's a minor complement component, but it's a breakdown product of C3. C3 can become C3b, which can then become C3d, and C3d normally binds to CD21. Besides being called CD21, this receptor goes by a number of different names. Some of them include the C3d receptor, the EBV receptor, or CR2. The classic presentation of infectious mononucleosis is a college-age student, about 15 to 20 years old. And this is part of why it's called the kissing disease, because college-age students will be kissing and they will spread the virus around the dorm. Patients will develop a fever, and then they'll get a large liver and a large spleen. And one of the dangerous consequences of this infection is to have splenic rupture. And people who have mono need to be careful if they want to engage in contact sports and other things where they could potentially rupture their spleen. These patients will have a sore throat. They classically get cervical lymphadenopathy in the posterior cervical region, and then they have atypical lymphocytes on their blood smear. These are T cells. We'll see a picture of these in a minute. There's no specific treatment for Epstein-Barr virus infections. Most symptoms resolve in a few weeks. One problem with this condition is the fatigue may last for several months, and so often college students can miss an entire semester of college because they caught mono. The hallmark of infectious mononucleosis is the atypical lymphocyte. This is a picture of one here on the screen. It's called atypical because it's larger than usual and it has a nucleus with dark nucleoli that you can see. The majority of these cells are CD8 positive T cells, and you can normally have a few atypical lymphocytes when you send a patient's blood to the lab, but in infectious mononucleosis they will get to be more than 10% of all lymphocytes. Often they'll get to be as high as 50 or 70% of all lymphocytes, and that's what's suggestive of the diagnosis of mono. There are a couple of ways to make the diagnosis of infectious mononucleosis. Sometimes it's done clinically. If a patient has classic symptoms and an atypical lymphocytosis, that can be enough to make the diagnosis. There's a quick test that you can often do in the office called a monospot test. This test looks for presence of heterophile antibodies. These are antibodies produced by the immune system in response to EBV infection, and these antibodies agglutinate sheep or horse red blood cells. There are simple lab kits you can use. You take a sample of the patient's blood, often just a finger stick, and there'll be a color change if the heterophile antibodies are in the plasma. This is a quick, highly specific test, but the problem is there are false negatives. And then there are EBV-specific antibodies that you can send a test to the lab for, and this is often done when the monospot is negative, but you still suspect an infection. A couple of Epstein-Barr virus extras. There is a phenomenon called the amoxicillin rash. Recall that patients with EBV infection and mononucleosis often have a sore throat. Sometimes they are administered amoxicillin thinking that they have a strep sore throat infection. When you do this, many patients will develop a diffuse maculopapular rash. The mechanism of this is not well understood, but this is a classic board question to describe a patient with a sore throat who gets amoxicillin and then gets a rash. What they actually have is an EBV infection and mononucleosis. Patients with EBV infection will have a false positive VDRL. The VDRL is a screening test for syphilis, and there are many false positives, and mono is one of them. Don't confuse this with a syphilis infection. And then finally, Epstein-Barr virus can sometimes become latent in B cells and reactivate later, and this often happens in patients who develop HIV/AIDS and become immunosuppressed. You should know that EBV infection is associated with many cancers. Some of the common ones include lymphomas, and this should make sense to you because you know Epstein-Barr virus can infect B cells, so it makes sense that it can transform those cells into malignancies. Some of these include Burkitt's lymphoma, which is a rare lymphoma that occurs in children in Africa, also Hodgkin's lymphoma and T-cell lymphoma. There's a rare tumor of epithelial cells called nasopharyngeal carcinoma that develops in the nose and pharynx, and in China and other areas in Asia, this has been associated with Epstein-Barr virus infections. There are several tumors that occur in patients with HIV that are associated with Epstein-Barr virus infection. It's believed that the immunosuppression of HIV allows these tumors to develop. These include non-Hodgkin's lymphoma and Burkitt's lymphoma and CNS lymphoma. And then finally, there's a rare condition called oral hairy leukoplakia. These are white plaques that occur on the tongue and they cannot be scraped off. And these classically occur in patients who have HIV and a very low CD4 count. These are often mistaken for thrush because thrush can also occur in HIV patients, and it occurs as white plaques in the mouth. But thrush is due to a Candida fungal infection, and thrush can be scraped off. This won't be able to be scraped off, and that's one of the ways you can tell that it may be this malignancy. Our next herpes virus is cytomegalovirus, and this is a ubiquitous virus that many of us are exposed to, but as we'll see in a minute, unless you're immunocompromised, it generally does not cause serious illness. It's spread in just about every way you can think of. There are reports of sexual transmission. It can be spread through direct contact with a family member or children at daycare. It can be spread by blood or tissue exposure, and it can also be spread perinatally, either in utero or during childbirth. There's a classic finding on biopsy of infected cells, and this is called the owl's eye nuclei. This is a picture of it up here. You can see that this cell right here has a dark nuclei that's enlarged. It's about half the size of the cell, and it's got white clearing around it. That's called a perinuclear halo, and this owl's eye nuclei is classic for cytomegalovirus infection. This virus can sometimes become dormant and lie latent inside of monocytes or marrow cells, and there are several unique drugs to treat cytomegalovirus infections. These include ganciclovir and foscarnet and cidofovir, and I talk about all of these in the module on antiviral drugs. So as I said before, this virus is mostly a problem for people who are immunocompromised. The one exception is that there is an entity called cytomegalovirus mononucleosis. This looks just like an EBV infection, but the blood test will be negative. The monospot will be negative, the EBV antibodies will be negative. This is a classic board question, and when you see this, you should think of cytomegalovirus. These patients are a little bit less sick than patients with EBV mononucleosis. These patients have less lymphadenopathy and less splenomegaly, but otherwise it generally looks exactly like infectious mononucleosis, except that the tests come back negative. Most of the problems that cytomegalovirus causes occur in people with HIV/AIDS or people who have had transplants and are on immunosuppressive drugs. Cytomegalovirus pneumonia is a major problem after lung transplantation. If you work in the field of lung transplantation and you have lung transplant patients on immunosuppressive drugs, you will have to deal with treatment and prevention of cytomegalovirus infections. CMV also classically causes retinitis in patients with very low CD4 counts who have HIV/AIDS. The CD4 count has to get to about 50 to 100 for this infection to occur. These patients will have retinal edema and necrosis, and they will complain of floaters and poor vision. And this is a picture of the fundoscopic exam of someone with CMV retinitis, and it's often described as looking like a pizza pie in the back of the eye. Women who get infected with cytomegalovirus during pregnancy can pass it on to the fetus, and CMV is one of the torch infections that are dangerous during pregnancy. Now, most babies who are exposed to cytomegalovirus in utero will be born with no symptoms. Some of these without symptoms will later develop progressive hearing loss, but at birth they will be normal and not appear to have any symptoms. Babies who are symptomatic can have a number of potential findings. Sometimes they're small for gestational age, and sometimes they have microcephaly, which is a small head. They can have enlarged spleens and livers. There's a characteristic rash called a blueberry muffin syndrome, and these babies have multiple blue-purple marks on their face and all over their body. You should Google the blueberry muffin syndrome to see a picture of what this looks like so you recognize it for your boards. These babies can also have seizures, and they sometimes have evidence of sensorineural hearing loss. And the defects are more common if the fetus is infected in the first trimester when the organs are growing. And you can sometimes treat newborn babies who have this infection with medicines like ganciclovir and valganciclovir. Let me just pause here and mention newborn deafness. So this is a finding of two different congenital infections. One is CMV, as we just discussed, and the other is congenital rubella syndrome. Now, both CMV and the congenital rubella syndrome can cause the blueberry muffin baby syndrome, so it can be confusing to tell the two apart. But make sure you remember that only CMV will give seizures and a big liver and a big spleen. Congenital rubella syndrome, on the other hand, causes cataracts in the babies, and it's often associated with congenital heart defects. The next herpes virus is human herpes virus 6, or HHV6. This is the cause of roseola infantum, which is also called 6 disease. Years ago, they numbered the childhood infectious rash syndromes, and there was first disease and second disease and so on, and this one was called 6 disease. That's how it gets its name. This condition is most often due to HHV6, but it can also be caused by HHV7 and some other viruses. And we don't really understand how children acquire this infection. It appears to occur sporadically, often with no history of exposure to a sick patient. HHV6 starts with something called the febrile phase. The child will have a high fever for several days. It's often a baby, and it will be very irritable. There sometimes will be swollen lymph nodes present, and this can sometimes get confused with meningitis, especially in a baby. Then the fever will break, and a characteristic rash will occur. It's a maculopapular rash that starts in the neck and trunk and then spreads to the face and limbs. And this is a picture of a baby who's got an HHV6 infection. It's a little bit hard to see in this picture, but this child has a maculopapular rash on the legs and on the arms, and that's what it looks like in patients who have roseola infantum. And this is a self-limited condition, and there's no specific treatment. Our final herpes virus is human herpes virus 8, or HHV8, and the most important thing to know about this virus is that it causes the vascular tumor Kaposi's sarcoma. This tumor occurs among patients who are immunocompromised. Classically, it occurs among patients with end-stage HIV or AIDS. This is sometimes the way that AIDS initially presents, is as Kaposi's sarcoma. The transmission of HHV8 is unclear, but what it does in the body is infects and transforms endothelial cells. And because it infects endothelial cells found in the vasculature, that's why it causes the vascular tumor Kaposi's sarcoma. The virus can inactivate tumor suppressor genes, and that's what leads to uncontrolled cell growth. And it presents usually on the skin as purplish plaques or nodules. Remember, it's a vascular tumor, so it's going to be filled with blood, and that's why the lesions are purple. This is an example of someone with Kaposi's sarcoma of the nose shown on the screen here. Also, these tumors sometimes develop in other places like the mouth, the GI tract, or the lungs. And that concludes our video on herpes viruses.